ವಿಚಾರವನ್ನು ಅಳವಡಿಸಿಕೊಂಡು ಉತ್ತಮ ಶ್ರೇಣಿಯಲ್ಲಿ ಉತ್ತಮ ಮಟ್ಟದಲ್ಲಿ ನೋವು ಮತ್ತು ತೊಂದರೆ ಇಲ್ಲದೆ ಶಸ್ತ್ರಚಿಕಿತ್ಸೆ ಮಾಡುವುದಕ್ಕೆ 2 ರೋಬೋಟ್ ಅನ್ನ ಫೋರ್ಟಿಸ್ ಹಾಸ್ಪಿಟಲ್ ಬನ್ನೇರುಘಟ್ಟ ರೋಡ್ ಒಂದೇ ಫ್ಲೋರ್ನಲ್ಲಿ ಪಕ್ಕಪಕ್ಕದ ಶಸ್ತ್ರಚಿಕಿತ್ಸಾ ಕೊಠಡಿಯಲ್ಲಿ ಅಳವಡನೆ ಮಾಡಿದೆ. ಈ ಒಂದು ಥಾಟ್ ಪ್ರಾಸೆಸ್, ಈ ಒಂದು ಆವಿಷ್ಕಾರ ನಾವು ಟ್ರೀಟ್ ಅಂತ ಕರೆದಿದ್ದೇವೆ, ಟೋಟಲ್ ರೋಬೋಟ್ ಎನೇಬಲ್ಡ್ ಅಂಡ್ ಅಸಿಸ್ಟೆಡ್ ಟ್ರಾನ್ಸ್ಪ್ಲಾಂಟ್ ಸರ್ಜರಿ. ಇಂಡಿಯಾದಲ್ಲಿ 5 ಡೋನರ್ ಕಿಡ್ನಿ ಡೊನೇಷನ್ ಬಂದಾಗ 4.5 ಡೋನರ್ ಹೆಂಗೆ ಸಾಕಿಸ್ತಾರೆ, ತಾಯಿ ಆಗಿರ್ಬೋದು, ಮಗಳಾಗಿರ್ಬೋದು, ಹೆಂಡತಿ ಆಗಿರ್ಬೋದು. ಆಕೆಗೆ ವಾಪಸ್ಸು ತನ್ನ ಜೀವನ ಶೈಲಿಯನ್ನು ಪ್ರೊಸೀಜರ್ ಆಗುವುದಕ್ಕೆ ಮುಂಚೆ ಹೆಂಗಿತ್ತು ಅದೇ ರೀತಿ ಉತ್ತಮ ಶ್ರೇಣಿಯಲ್ಲಿ ಲಾಭ ಮಾಡೋದಕ್ಕೆ ಈ ಒಂದು ಆವಿಷ್ಕಾರವನ್ನು ನಾವು ನಿಮ್ಮ ಮುಂದೆ ತಂದಿದ್ದೇವೆ. ಇದು ಯಾವುದೇ ಒಂದು ವೆಚ್ಚದಲ್ಲಿ ಹೆಚ್ಚಳಿಕೆ ಆಗದೆ ಇಂಡಿವಿಜುವಲ್ ಪೇಷಂಟ್ಗೆ ಲಾಭ ಆಗೋ ಒಂದು ಯೋಚನೆ ಏನಿದೆ, ಆ ಕಾರಣಕ್ಕೆ ಇದನ್ನು ಅಳವಡಿಸಿಕೊಂಡು ನಿಮ್ಮ ಮುಂದೆ ತಂದಿದ್ದೇವೆ. Urology program in India in the private sector. We have 30 urologists working together across.
Once the robot is connected, here we are dissecting the blood vessels. The blood vessels which go along the right side of the thigh, just above the thigh, those are called iliac vessels. So we dissect them. We can see how the robotic instruments move inside it. They mimic the natural movements of the hand, which is not possible with the laparoscopic surgery. To put hands inside, as I said, you need a big incision. So all this can be overcome with the help of robot. So now we are dissecting the vein. Surgeon will be comfortably sitting and operating. So both the surgeon and the patient are at benefit. Surgeon will not be tired. He can focus on the surgery, and this is a 3-dimensional high definition vision. It will be 30 times magnification will be there. So now we are putting the kidney inside. The incision will be only about 6 to 7 centimeters. So once the kidney is placed inside, we are temporarily blocking the blood vessels. Vein will be anastomosed first. The needle what we use is only 9 millimeter. Because of the magnification it looks big. It is almost the size of an eyelash. So another advantage is when we do open surgery, we will be standing and operating. So the distance to the operating field will be almost 45 centimeter to 50 centimeter. Here we can take the camera right next to where we are stitching, and each stitch can be taken under vision with more precision. Blood loss will be very less. Stay in the ICU for about 3-4 days, then they will be shifted to the ward. Compared to the robotic transplant, you can see only 8 millimeter, 3 cuts, 4 cuts will be there, and another cut wherein it's only about 6 centimeter. We cut only the skin. The muscles are separated. The muscles are not cut. So the post-operative pain will be very less, and patient can be shifted out of ICU maybe on the first or second day itself, and patient can be discharged by 4th or 5th day.
Be here as always. I think Fortis in Bangalore is truly special for Fortis Healthcare as a network. We are always amazed by the kind of clinical excellence and the cutting edge work that happens here. The Center of Excellence in Renal Sciences led by Dr. Keshav Murthy is a stellar example of the innovation and the cutting edge work that we are able to do, and we are so proud of and love to support every single time. When robotic surgery started many years ago, a lot of people probably started with a lot of skepticism. And you need a leader to understand the power of technology and to adopt it in what they do. And I think that is where.
Good afternoon. My name is Dr. Mohan Keshavamurthy. I'm Principal Director, Renal Sciences, Fortis Hospitals, Banerghatta Road. I'm also the Chairman for the Urology Specialty Councils, Fortis India. We are here today to announce the start of a technological marvel in terms of kidney transplant in the country. The ability to perform robotically using the Da Vinci Xi for both the donor and the recipient in two parallel OTs in real time. This has enabled us to perform transplants from donors who otherwise would not have been eligible to provide their kidney, whether it be a right-sided kidney, a kidney with multiple arteries, an obese donor, a donor who has undergone multiple surgeries in the past. The idea here is donor advocacy. Most donors in India are females, 4.5 out of 5, and they have to return to multiple roles in their family. We wanted it to be a painless, minimal scar experience where they could go back to the social life they would wish if they had not undergone this procedure. At the same time, it allows us to accept very difficult recipients, second transplant, third transplant, fourth transplant, or pediatric patients who again would not have been welcome for recipient surgery elsewhere. This overall technique is called TREAT, Total Robot Enabled and Assisted Transplant Surgery. We are providing it at a reasonable cost considering it is an innovative technique. We would going forward get this technique across both nationally and internationally by training urologists interested in transplant surgery in this newer form of providing better individual care to both the donor and the recipient to enhance acceptance of living related transplant. As we know, in our country, diabetes is is an epidemic, and since we are living longer, diabetic nephropathy and kidney failure and the need for dialysis is increasing at an exponential rate. We need to provide solutions in terms of greater human acceptance of donating cadaver donor or brain dead donor kidneys so that the pressure on living related transplant will come down. At the same time, we are using technology like TREAT to enhance donation in the living related realm of kidney transplant. Thanks for your patience. Thanks for your consideration.